Hello, and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on acute asthma under the section of respiratory medicine. So just a recap of what is asthma. Remember, it's a reversible airway obstruction associated with inflammation and bronchial hyperresponsiveness. Due to various local stimuli, including histamine, leukotriene, and prostaglandins, is basically the underlying pathophysiology of the disease. The risk factors for acute asthma remain the same as chronic asthma. However, there are some factors that are playing more of a role in acute exacerbation. And in real clinical practice, infection and non-adherence to inhaled medication are two of the big ones. However, just as a recap of overall risk factors for asthma, these include genetic predisposition, personal history of atopy, family history of atopy, maternal smoking and ethnicity, socioeconomic status, air pollution, house dust mites, pollen, mold, fungi, cat and dog dander, aspirin and NSAID and beta blockers, occupational exposure, exercise, infection, GORD, cigarette smoking, and failure to comply with medication. In terms of the symptoms of acute exacerbation of asthma, the commonest ones are breathlessness, tightness of chest, wheeze, cough, sputum production, and these symptoms are typically worse at night. The British Thoracic Society has very clear guidelines and definitions of dividing flare-up of asthma in an acute setting into moderate, severe acute, life-threatening, and near fatal. These are really quite important because the escalation of care and the management of patient will be really different in each of them. And it is crucial that all of you guys are familiar with, not just for the purpose of exam, but also for real clinical practice when you are clerking patient on an acute unselected medical take. So, for moderate asthma, you will need to have increasing in symptomatology. Your peak flow will be between 50 and 75% of your predicted best, and you won't have any other features that would put you in any of the other three categories, which include severe acute, life-threatening, and near-fatal asthma. For severe acute asthma, any of the following will automatically put you in the severe acute category. These include a peak flow between 33 and 50% of your best or predicted best, respiratory rate of more than 25, heart rate of more than 110, and inability to complete a full sentence in one breath. For life-threatening asthma, if you have any of the following features, you will automatically be categorized as a life-threatening asthma. These include a peak flow of less than 33% of your best or predicted best, an arterial blood gas saturation of less than 92%, partial arterial pressure of oxygen of less than 8, a normal partial arterial pressure of carbon dioxide or a PCO2 of between 4.6 and 6, a silent chest, cyanosis, poor respiratory effort, any types of arrhythmia, exhaustion, hypotension, or altered levels of consciousness. And for the near fatal category, you will need to have a raised PCO2 and needing mechanical ventilation with raised inflation pressures. So by the time that the patient is approaching acute severe, you need to be thinking about contacting your respiratory team and or your intensive care unit for further support, because these patients can deteriorate really quickly, and that's certainly not something that you would want. As for its presentation, we have already talked about this, but just to recap, patient can present with acute worsening of breathlessness, wheeze, and hypoxia, with or without carbon dioxide retention, which could lead to acute confusion. But always remember, having a normal carbon dioxide in a patient with true asthma who's presenting with a flare-up is bad news, and that is an indication for you to talk to your intensive care unit. As for its investigation, history and examination remain key like any other medical condition. It's really important that the patient is observed frequently and the arterial blood gases are performed in order to have a better understanding of the partial pressure of oxygen and carbon dioxide. Having a peak flow meter is crucial, and this is something that unfortunately frequently missed in real clinical practice. So doing a serial peak flow on somebody who's presenting with an acute flare of asthma will help you to categorize them appropriately so the treatment is appropriately given and escalated. And having a chest x-ray, particularly to check for pneumothoraces. Remember, people with asthma have, especially those who are having an acute flare, have a higher risk of having pneumothoraces. And this is something that you certainly don't want to be missing before talking to your intensive care unit. The management depends on the severity. However, broadly speaking, patients need to be supported with oxygen therapy, and if need be, that would need to be high flow oxygen. Nebulized bronchodilators, including salbutamol and ipratropium. Corticosteroid at the dose of 40 mg per milligram of prednisolone is indicated. Antibiotic is frequently prescribed, especially if there is suspicion of superadded bacterial infection. If there is no improvement with nebulized or IV salbutamol or aminophylline, then another good drug to consider would be IV magnesium. This is normally given at a dose of 2 to 4 milligram intravenously. And if the patient is still not improving despite these treatment, then by definition, they are acutely unwell and they would be at the category of either life-threatening or severe asthma. And then prompt discussion with the intensive care unit would be indicated. So let's do some questions. Question 1. A 30-year-old lady presents by ambulance to the emergency department. She has a known history of asthma. She is dyspneic with an audible wheeze and her respiratory rate is 28 breaths per minute. Her initial oxygen saturation is 88% on room air. Her peak flow is 20% of predicted. Her examination reveals an irregular heart rate, which is new. An arterial blood gas reveals a CO2 within normal range. What is her class of asthma severity as per the above information? A. Mild, B. Moderate, C. Severe acute, D. Life-threatening, and E. Near fatal. And if you go back to the vignette again, you have somebody who's a known patient with asthma, who's coming in with audible wheeze. Her respiratory rate is 28 and SATs of 88. She does have arrhythmia that is new for her, and her ABG shows that CO2 is normal. Hopefully, if you've been listening so far, you would realize that this is bad news. And if you have somebody in that scenario, according to the NICE or British Thoracic Society guidelines, whichever you go with, this patient is automatically classed as life-threatening asthma. Therefore, the correct option is option D. Thanks for listening to this episode of Bite-Size MRCP. If you like what you heard today, give us a thumbs up and hit the like and subscribe button to make sure that you don't miss out on our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.